I do not believe that neurologic toxicity or cytokine release syndrome should be managed in the outpatient setting. This should be a mandatory admission to the hospital if patients develop these significant symptoms. And so at our center, significant fever in the outpatient setting after CAR T-cell is a mandatory admission for monitoring and treatment. As more experience is gained, then it is possible that if a product is associated with low-level CRS that doesn't require intensive fluid support or oxygen support or ICU care, that this could change. But I don't see that happening anytime soon. All the products can be associated with severe symptoms associated with cytokine release syndrome and neurologic toxicity. Grade 2 CRS is not managed in the outpatient setting. That is, it requires hospitalization urgently, and even grade 1 should be managed, in my opinion, should be managed in the hospital.
There have been 3 trials which have looked at the safety and efficacy of CD19 CAR T therapy in relapsed refractory B-cell lymphoma. The ZUMA study, which looked at Axi-cell, the Transcend study, which has looked at Lysocell, and then the third study has been the JULIET study, which has looked at CTL019. All 3 studies have shown efficacy in these very refractory and relapsed B-cell lymphoma populations. Specifically, the ZUMA study, which was reported in New England Journal of Medicine and then updated at ASCO 2018, showed an overall response rate of 82% and a complete response rate of 58%. Importantly, there were patients who had a partial response initially, which converted into a complete response. In terms of side effects on this study, 94% of patients had cytokine release syndrome if you include all grades, and 13% had grade 3/4 cytokine release syndrome. In terms of toxicity, for neurotoxicity, 64% patients had neurotoxicity if you include all grades, and a smaller number, 28%, had grade 3/4 neurotoxicity. There were 3 deaths from toxicity on this study. On the JULIET study, which was looking at CTL019, the overall response rate was 52% and complete response rate was 40%. This was evaluated at 3 months, which is a very important endpoint for looking at durability of responses. The neurotoxicity in the study was not as much. It was less than 10% in terms of the more serious neurotoxicity effects. And then the cytokine release syndrome on this study was 52%, with 22% getting grade 3/4 cytokine release syndrome. In this study as well, about half the patients who had a partial response converted into a complete response with longer follow-up. About 40% of patients in both the ZUMA-1 and the JULIET study seem to have a complete response at 3-month period. Finally, looking at the Transcend study, which has been updated at ASCO 2018, the overall response rate is 80%, the complete response rate is 59%, and the complete response rate for the core cohort, and which is what I'm describing as I speak about this study, is 45%. Very importantly, the side effect profile is favorable in this study. The overall rate of CRS, if you include all grades, is 37%, and only 1% had grade 3/4 CRS. The overall neurotoxicity rate is 25%, of which 15% was grade 3 or 4. In all these 3 studies, tocilizumab was used for treatment of CRS, and dexamethasone in combination with dexamethasone as appropriate. And dexamethasone was used for treatment of neurotoxicity in conjunction with tocilizumab if there was CRS in addition to neurotoxicity. Now, it is the overall management of CRS and neurotoxicity is complex, and there are algorithms in place. But in general, depending on the grade of these toxicities, they may need just supportive care if it's very low grade, or higher level of treatments if they are more severe grade. In terms of cytokine release syndrome, fever is usually the first sign of this thing happening, and you try antipyretics like acetaminophen in that situation. If the blood pressure drops, then fluids are the first thing to do. But then as it can get more severe, there could be capillary leak, and in those situations, use of pressors, vasopressors, they may also need oxygen, and then the use of tocilizumab can really mitigate these cytokine release syndrome and prevent it from getting worse. And this is extremely important because early intervention has been shown to be very helpful in preventing many of the severe side effects from happening. And also what has been shown is early intervention with these agents does not seem to interfere with the efficacy meaning the positive outcome at the end. So that is important. And in terms of neurotoxicity, dexamethasone is really the primary or some other form of steroid, depending on the severity, should be used. And if there is more severe CRS, then higher doses of steroids are used. There's always a concern when higher doses of steroids are used is what would happen to the CAR T cells, but that is used as a last resort in case of severe side effects. Finally, anti-seizure prophylaxis is considered because seizures are a part of the neurotoxicity. Other things with neurotoxicity include confusion, encephalopathy, and aphasia, and those are things which can be worrisome. But the important message over here is if intervened and treated properly, then majority of these side effects are reversible. And as you can see from the 3 studies, that there is very little mortality from CAR T therapy. In fact, in the JULIET study and in the TRANSCEND study, there were no deaths from CRS or neurotoxicity, and in the ZUMA study, there was a 3% mortality, which is still a fairly low number, considering that a lot of patients did get neurotoxicity and CRS. The last thing which I want to mention is that we don't have very long-term data. However, the 3-month time point seems to be a very important point for assessing responses and can help us in predicting what the long-term outcomes might be. So across the 3 trials, it appears that at least around 40% to 45% of patients may be in remission at 3 months, and these with the limitations of not having very long follow-up, it appears that if they are in remission, especially complete remission at 3 months, that is going to be a durable response.
As you've heard, there are different profiles associated with the 3 different CAR T cell products that are either in commercially available or in late-stage clinical trials. And there does appear to be some differences in terms of the rate of onset of cytokine release syndrome, the total overall grade of that cytokine release syndrome in terms of the severe grade 3 and 4 toxicity, which seems to be less with the lisocabtagene maraleucel, at least in the clinical trial results that we have to date. And this then could provide some advantages in number of hospital days required. So I think healthcare economics could clearly be a major factor in determining this, which products will be the most successful in the marketplace eventually. But this also will depend on efficacy holding up over the long term. And so this is a very complicated issue. And as we get more and more competition in the marketplace, then this will allow these differences to maybe become more revealing.